Hello and welcome to our special live streaming series, COVID-19 Frontline on CGTN. I'm Zhou Yun. COVID-19 Frontline is a special live show for medical experts from China around the world to share their thoughts and experiences in prevention, control, and clinical treatments of COVID-19. And apart from discussions from our medical experts, we also take questions and comments from followers on various social platforms, such as CGTN app, the official account, on a variety of different platforms, such as CGTN app, the YouTube, Twitter's, and also Sina Weibo and more. So feel free to leave your comments and questions on those platforms that I have just mentioned. And we do leave them. Please remember to use the hashtag of my opinion on COVID-19. We look forward to your sharing. And today we have experts from China, Jordan, as well as Palestine. And all the medical experts from China has actually the frontline experience in fighting the battle in Wuhan, which was the hardest hit city here in China. And they have fought the battle and treating patients with incredible bravery as well as exceptional medical skills. So thank you so much, everyone, for joining us today. And first of all, please let me introduce the expert from China. And they are, first of all, Dr. Wu Dong, who's the Associate Professor in Gastroenterology from Peking Union Medical College Hospital. Thank you so much, Dr. Wu, for joining us. And it's also our great pleasure to have Dr. Fan Junping back again, and he's the attending physician at Department of Pulmonary and Critical Care Medicine and Peking Union Medical College Hospital. Thank you so much, Dr. Fan, for coming back. And also we have Dr. Ding Xin, who's the attending doctor from Department of Critical Care Medicine, also from Peking Union Medical College Hospital. So thank you so much, gentlemen, for joining us today. And also we have international guests. And without further ado, I would just like to open the floor to our international guest, and you can just feel free to answer questions which are concerning to you. And before you ask the very first question, please make a very brief introduction about yourself. Thank you. And why don't we start from Mr. Saleh? How about we have you asking the first question? Thanks.
Well, I said.
Yes, please go ahead.
Yeah. I'm Dr. Salah, Osama Salah, a clinical nutritionist and public health specialist. I'm happy to have this conference with you guys. I'm really, myself and the Palestinian people in general are highly impressed by the great distinguished jump of China in all aspects. And we hope we all recover from this ghost, the COVID-19. And I'm happy to join the experience, which you are highly advanced in this way in protecting, treating, curing, and a lot of follow-up procedures. Is it okay if I start my first question?
Yes. Yes. Please go ahead.
Yeah. Okay. Actually, we have plan. I hope we have enough time for it. But basically, what we are concerned about the immediate current medical treatment in the time being. You guys as specialists do it and follow it in regarding treating the COVID-19 and. When it is started, because everybody knows if we start early, it's better than starting late, even if there is a proper treatment for it. But if it is late, it is too late. This is my third question. Please answer.
So, who should answer this question? Dr. Fan, you need to turn on the audio before you speak. Thank you.
Oh, yeah.
Yes, Dr. Fan, you can go ahead, and then we can have Dr. Wu to add on that. Turn on the audio. Thanks. Now it's good.
Yeah, Dr. Salah, are you asking about?
Yes.
Were you asking about the question about the antivirus or the specific medication for COVID-19? Am I right?
I know there is. I know there is a definite. Credited treatment in the time being, but at least how you manage it if you are encountered with an immediate infected person with this disease.
Okay, from the perspective of a pulmonologist and a critical care practitioner, we would like to divide the patients or general population into three groups. The first one is the general population. For them, the priority number one is prevention. You never want anybody, any family member of yours to get the disease. And if someone is unfortunate to have this disease already, they can be divided into mild to moderate disease group and also the critical group. For the first group, I believe the disease tend to be self-limiting. You spend 1 or 2 weeks, he or she will recover. And for the second group, which we treated a lot in Wuhan in the last 3 months, we believe the most effective or efficient way is a holistic supportive measures, including appropriate mechanical ventilation, secondary infection prevention, generally supportive. Some of the patient will recover. But as you might see, the mortality of this group of patients are generally high all over the world. In European countries and the United States, the mortality rate of mechanical ventilation patients can be as high as 60% to 80%. We have encountered the same problem.
Okay, I think there might be some technical problem encountered by Professor Salah because now we're seeing him offline. But Professor Wu, do you have something to add on that question? Please go ahead.
I totally agree with what Dr. Feng had commented. But I do have some of my own comment is that, first of all, we do realize that there's no specific definite antiviral medication so far. So all that we can give the patients is all about supportive care and also some medication to handle the complications such as thrombosis. So we use a low molecular weight heparin to treat them, and also from a gastroenterology perspective, enteral nutrition is very important. We want to give them to those critically ill patients ASAP. That's my opinion. Thank you.
Okay, thank you. How about Mr. Amlach and Mr. Saleh? Do you have any questions? Just feel free to ask them.
Good evening for all. Thank you for this conference. My name is Isa Al-Amla, specialist of internal medicine in Jericho Hospital, ICU and medical ward. We are in contact with a little amount of patients who have COVID-19 because our country is small. Till now, we have only 500 cases diagnosed with COVID-19. We have 3 cases died till this moment when I talk with you. Because our government state care review initially about 2 months ago stopped all the movement in the country and all the border access is closed now. Our question and our see with the patient, most patients in our country is asymptomatic. We are put the patient in the isolation only without any treatment. But we have 3 or 5 patients put in the ice in the ventilator, and after 5 to 7 days we are improve the patient. My ask question now in China experience about a lot amount of the patient. What's the best time to put the patient in the mechanical ventilator? Can I wait late time or can I put the patient initially at the mechanical ventilator to expect about outcome about this main question in our country? We don't have enough experience to contact this patient. And another question about the incubation period of the disease. We are see and read about 14 days. It's enough to not transmission the disease. But we are see patient diagnosed with COVID-19 about 1 month and 5 days till now still positive and asymptomatic. Is this patient can transmit the disease to another person or only 14 days? We are read sometime in 28 days is enough to transmission as incubation period. This question take many idea and I read many idea about that and not have final answer because no enough experience. I think the enough experience now in the China because the source of the disease started in the Wuhan. And another question, we are in Palestine whose symptomatic patients start as azithromycin as medication and hydroxychloroquine would observe the cardiac complication to avoid QT prolonged in the ECG. And we use, if we found high D-dimer and high LDH, we use nixobarin as full therapeutic dose for prevention the embolism. Is this management is enough with your experience? And thank you.
Thanks.
I think the first question is best going to Dr. Dingxin because he's the intensivist in our team. And I will take the second question.
Okay, I just I have to make sure that you means mechanical ventilation is invasive mechanical ventilation. Did the non-invasive ventilation included in your questions? Because we have just a doubt that in our country at the very beginning we just have some controversy, and some experts say that most of the patients have to they just need to non-invasive ventilation, and if you intubation and after the mechanical ventilation, the patient will get worse. But in our experience, we think that just as the paper published in intensive care unit, they said that at the beginning, the symptoms of the patient remain unchanged for a period. Maybe the patient will have very, very low oxygen saturation, but the symptoms is worse. And at that time, maybe the possible key failure that determines the evolution of the disease is not the disease itself, but the depth of the negative intrathoracal pressure associated with the increased tidal volume, because this patient suffered from dyspnea, and that caused patient self-induced lung injury. And we think that that is worse than the symptoms caused by the virus. So we insist we have to intubation at the very beginning. And if the patient have symptoms of dyspnea, which means higher respiratory rate or lower or severe hypoxemia, we have to intubation and give this patient enough support, mechanical support, and let the patient doesn't suffer from the patient self-induced lung injury. And at that time, maybe if you just control the complications, the patient will get better. And that is what we do in Wuhan, in our ICU. We can see that at the very beginning, if you just use the non-invasive mechanical ventilation for a long period, and most of the patient will be very, very severe when you have to do the intubation. But if you just give the patient enough mechanical support at the beginning, where the patient developed dyspnea, and this patient will recover after a period of treatment. So that's our opinion. You have to just judge if the patient developed dyspnea or hypoxemia, and you have to just intubation the patient and give them mechanical support. After the comprehensive ICU support, that means enteral intubation, nutrition, and just the prevention of the hospital-acquired infections, and this patient will get better for a period of time. Oh, that's all. Dr. Wu?
Okay, you talk about asymptomatic carrier of COVID-19, and also you put a question about how long we should isolate these potential carrier and patients. So first of all, we admit that we also in China, it's true that we do have some a few patients or a few carriers totally without any symptom, but test positive for COVID-19. But also we should emphasize that the number of this group of people are still very few as compared with those symptomatic patients. But we still don't know if these patients without treatment, will they develop symptoms afterward. We don't know that yet. But the standard procedure in China still, we isolate those suspected cases and carriers for as long as 2 weeks. and we used nucleic acid test for twice, because we know that the false negative results of such kind of tests could be 20% to 30%. So just to make sure that we will test for twice. If still you have doubt about that, we suggest that probably maybe you can test the serum antibody for the virus. But the problem with the antibody is that it will not test positive for within a week. So the test of the positive antibody only indicate that this guy had previously contracted the virus. He may not carry the virus alive, still in his body. So this is the procedure in China. But we also should judge from the local, resources and also these requirements of medical practitioners. So it's still your call. But our opinion is that 2 weeks for a vast majority of cases is enough. Thank you.
And you have just mentioned about another medication called azithromycin plus or without hydroxychloroquine. Where we have been asked about the usage of hydroxychloroquine for quite some time. We generally, have negative attitude on this medication, especially among critically ill COVID-19 patients. Previously we recommend if there is no evidence and you believe you should use it to do something, you can use it. But right now, I believe some evidence, controlled trials have come out with a negative and even harmful results. So again, we're generally negative for the usage of hydroxychloroquine.
Okay, thank you so much, doctors. How about so Dr. Karajach? So great to have you. And so what is your question? And just make a very brief introduction by yourself before you ask the first one. Thank you.
Good afternoon, everyone. I have mainly 3 questions we confused to deal with the patient with COVID-19.
Yeah, but you can ask the first, you can ask them one by one.
Okay.
Thank you.
First question, we diagnosed the patients who have COVID-19 by swab, by nasopharyngeal swab. Now, after 2 weeks, and I have patients 30 days and 55 days, still they have positive in nasal swab for COVID-19. Sometimes they came negative, next day or next 48 hours they return back positive. This is happening with me in many patients. I didn't have explained this for my patient. I need help why this has happened.
Okay.
Do you need the second question or one question?
Yeah.
One question at a time.
Okay.
So I will take your question. Yeah, it's true. The same or similar things also happen here in China, but the numbers are low. I will say that, this is about the sensitivity and the specificity of the test that we are using. So generally speaking, there are certain false negative rate of the nasopharyngeal swab test. It depends on the assay kit that we are using, because we have so many commercially available kits on the market now. They may have different performances. This is the first point. The second point is that it also depends on the practitioners who are using the swab to take the sample. You need to push hard a little bit to get enough secretions from there. So if you just slightly rush in, rush out, you may not take adequate secretions for you to analyze. So my suggestion that for those highly suspected cases, we need at least 2 times of the test to rule in or rule out the patient. That's my opinion.
Thank you, Dr. Wu. So, Dr. Fan or Dr. Ding?
have something to add. And actually, we didn't just diagnose the COVID-19 disease just on the swab or nucleic acid. Actually, if you want to diagnose a patient, you have to information about the history, the contextual history, about sometimes you have the symptoms, and you have sometimes we have the CT scans. And actually, earlier in Wuhan, in China, some of the patients, they have negative nucleic acid, nucleic swab, but they have positive CT scans. And after a while, they just found that some patients have the positive nucleic acid scan swab. So just apart from the false negative or false positive, you have to think that just the nucleic acid is not the only method to diagnose the COVID-19, and you have to make sure that if the patient have other symptoms and the contactable history is very important.
And after the treatment and observation, some patients can turn negative, but still there is a certain percentage of them, around 10 to 15%. The patient will have positivity again, which means he or she has negative results, but later, if you do the PCR again, she will have positivity. We have had those cases here in China. Well, it is also due to the shortcoming of PCR tests. It's too sensitive. You never know behind a positive result, the virus is causing the problem, or it's just the body of the virus. Right now, just to be cautious, we would like to put those patients or even recovered under close investigation to see whether they can pass the disease to others. But generally, we are optimistic just because there are like about 30 or 70,000 patients who have recovered from COVID-19 in China. But most of them are still at home right now. They are not quarantined anymore, but there's no outbreak seen. So we're just optimistic, even there's a kind of high prevalence of repositivity. We generally believe it might be due to the false positivity of PCR tests.
Okay. So yes, gentlemen, just feel free to ask your next questions.
Okay. Following my question is, who can tell me when the patient with COVID-19 after 2 weeks or 20 days, he is not contagious in this time, despite the swab result? Why I ask this question? Because we have now our patient in the quarantine area, they became bored. As you know, in my country, in Palestine, all positive COVID, we put him in quarantine hotels, and also who need management. We
it seems that we lost his audio, right? Can you hear?
Yes, we can hear.
Can you repeat the second half of your question, because we can't hear you? It seems you're losing your audio. We can't really hear you, Doctor. Yeah, it seems he can't hear us either. So for my colleague, so can we ask him to log out and then log in? We can't hear you, Doctor. So how about we have Dr. Salah ask the next question, and then I will have my colleague to contact Doctor. Would that be good? We can't hear you. Yes, Dr. Salah, you need to turn on the audio before you speak, and let my colleague contact Dr. Murad. Dr. Salah, you need to turn on the audio. You're now still muted.
Yeah. Okay. Can you hear me now?
Yes, we can hear you. Please go ahead.
Yeah. I'd like to know what are the unusual or unexpected signs and symptoms you guys saw in your hospital regarding what is known cough, fever, dyspnea. A lot of signs, symptoms, we hear it from here and there. So I like to hear it from you guys.
I think Dr. Fan is the best person to answer this question.
Okay, Dr. Well, I'll pick this up. Well, thank you for the question. Generally, we believe, from a perspective of pulmonologist, it's generally, viral disease affecting the respiratory tract. Some people can contain the virus in the upper respiratory tract, but someone, a proportion of them will have a lower respiratory tract disease. They are going to be moderately ill or even critically ill. I believe the symptoms of these patients are generally non-specific. They are very similar to other viral diseases affecting the respiratory tract. Generally, we have fever, we have sore throat, and also people will have systemic symptoms such as fatigue and loss of appetite. A part of them will have like GI symptoms, including diarrhea, but not very many, not so many. We have to focus. We generally have to focus.
Sorry, yes, Dr. Murat, we can hear you now, but because now we just lost your signal, so maybe we can go back to you after Dr. Fan asked this question. Okay, so Dr. Fan, please go ahead. Sorry.
I'll continue. I believe the critical part or essential part of this is to sort out those patients who are having severe diseases. Generally, they are going to have dyspnea and hypoxemia and elevated RR rate. They are the dangerous patients. They are going to have a poor prognosis. For mild to moderate disease patients, they are generally self-limiting. Symptoms come and go, and even a greater proportion of them are symptomatic.
Any discolorations on the skin, on the let's say extremities, on the hands, the teeth?
Wait a minute.
Well, this is a good point. We have seen a lot of people who are staying in the ICU have ischemic gangrene. It's aseptic. It's not due to infection, but due to thrombosis. They're going to have black fingers, black toes, which is a very poor indicator for very poor prognosis. Yes, there are skin changes, and also we are quite worried about it.
Okay, thank you. Want to go back to Dr. Karaja?
Yeah, I'll try, but I think he's on phone now. Maybe we can go to Dr. Amlach.
Maybe can I ask a second question regarding some kind of psychosocial?
Yeah, of course. Go ahead.
Observing the patients, or whether they're infected, or the contact of the infected people in the quarantine, whether in the hospital or in the house. What are the psychosocial negatives, let me say, that have been noticed on those people from your experience?
You mean socio-economic lower status? You mean these patients?
We know the economic, it's kind of crisis, there is an economic shutdown, but regarding the psychosocial, like all people, they are not used to retain them in one room, for even a couple of hours, about a few days. Some kind of let's say unusual behaviors, being aggressive, being depressed, being losing appetite, being missing people, crying. I don't know. There are a few things like that. So maybe because you have you are acquainted with so many people regarding in our areas around a few hundred, which is nothing, in comparison to the thousands. So please go ahead.
Yeah. You raised a very interesting question. People need space in daily life. That's true for sure. But in China, we built those, the hospitals to admit all those cases in Wuhan. So usually you will see hundreds of people share one, big house, the cabinet hospital actually. So
it's like a stadium. It's like huge. Yeah.
It's like a stadium. Yeah. So it's true that people will feel, their space are narrowed and there's not much privacy there. But I think our government has done a pretty good job. So if you can take a look at the inside, the infrastructure within that stadium, the hospital, you will see that we have did our best to provide those private room for every patients. And also, you know that China, we are with the largest population in the world, so we have been already crowded already. So before this pandemic, so I don't think this is a major issue here.
Yeah, regarding let's say even if it is 7 stars hotel being in between brackets jailed in one room for a long time, that's it's not an easy situation.
Even for us, because we have returned from Wuhan to Beijing and we have been isolated in a hotel for 2 weeks already. So every one of us are getting bored, and we are looking forward to go back home ASAP. Yeah.
Inshallah, God bless your heart.
Yes, and you can see that we can do a lot of things when you are in the quarantine, because maybe we can share our experience with you, and we can just have some TV show and some news show via the internet, and we have everything to do, and we can communicate with each other via the phone or via the internet. So we don't, all of us don't have some psychosocial effect. And I think most patients and most people in China, they just have their way just to have this time, and we don't have heard any just the social efforts of the quarantine.
Right. So now let's try with Mr. Murat, with Dr. Murat. So can you ask the second question to see we can hear you, because just now we lost your audio, it seems. Yes, please go ahead, doctor. So Dr. Karjak, can you hear me? And if you can just proceed with your second question. I don't think he can hear me because I don't see any responses from him. So maybe I can have my colleague to keep trying to contact him. And now we can go back to Dr. Amlach. So doctor, do you have any question? You can just feel free to jump in. You need to turn on the audio because now it's all muted.
Okay, I have another question. We have a patient stay at hospital about 20 days, repeat 3 sample nasopharyngeal swab and 3 sample negative after every 3 days, and we make discharge to home to keep isolation at home. After 5 to 7 days, 3 to 5 patients return the symptom, cough and dyspnea, and return readmission to our hospital and found nasopharyngeal swab positive. Do you have experience about this case?
Yeah, we understand your concern. Well, because in Wuhan we have attended patients who are all critically ill. They generally stay in the ICU. We are worried about your type of patients too. Have the disease again. Right now, the current evidence does not rule out the possibility of reinfection. Maybe the patient had the disease, had a recovery, and also had a negative PCR tests after 2 or 3 weeks. Then later they were discharged and have repositivity. We have encountered that. We're not sure whether the patient will have long-term immunity. But if you do have discovered those patients, just put them under very close observation to see where they goes. Also, we do recommend you should have a survey on their close contact to see whether after recovery and again repositivity, whether they pass the disease to others. It will be very beneficial for the whole community, for the whole medical community. We are very concerned about these patients too.
Mm-hmm. So we can just proceed with the questions now. It seems that we have some audio difficulty connecting with Dr. Karajak. So yeah, so Dr. Amlath and Dr. Salaks, you can just feel free to ask more questions.
Yeah, I have a question regarding the world map coronavirus spread, which is good now. I see China at the bottom list, which is good. That there are no more new cases and everything is under control. And we're happy to see this situation in every country. Do you think you guys reached the peak for the cases of COVID infection, or and if yes, do you think there will be another peak or another outbreak in the coming few months?
Thanks for your encouragement, and we are also happy to see that, and we are looking forward to see all the countries, all the people won the battle against COVID-19, and the life in China is getting back to normal gradually, step by step. So I'm not an epidemiologist, and I'm not a good but according to my personal view is that we couldn't rule out the possibility that there will be a second outbreak, because the virus evolve. They can, get some mutations and to escape the immunological surveillance inside our body. So we do not know if there's a long-term immunity against that. So I think China, together with other countries, particularly United States, are working extremely hard to develop vaccinations. I think the vaccines will be the best, solution for the virus that we are talking about now.
How far are we from this kind of vaccine, from your experience and knowledge from the people around you?
I'm not an expert either, but I know that we are spending huge resources in developing vaccines. So hopefully we can see it, probably early next year, or even luckier to see it to the end of this year. Well, we don't know.
I hope so. Back to the question Dr. Isa Amla asked regarding the reinfection. Could it be from the same virus, or it has to do with the immunity of the infected person that it came down, or some kind of mutant happened, so another infections, or the same person got infected from this way?
This question goes to Dr. Fan.
Well, again, we're not sure what's going on right now, after those patients, behind those patients. I believe there are several scenarios which we can consider. The first one is repositivity. Just because we have mentioned previously that the symptoms of this disease, COVID-19, is non-specific. And also, for a respiratory disease patient, the symptoms always can be faked. You will have cough, you will have other things, just because you feel that you have got the disease. So the scenario one might be the patient is suspecting they have a reinfection, but actually they are just having a repositivity. The repositivity ratio here in China is above 10%, which is documented. But we don't believe all these repositivity means the patient has the disease again. And also, it does not mean the patient can pass the disease to others again. That is the critical part of the question, whether the repositivity means a true reinfection, and whether they can pass the disease constantly to other people. That's the priority one. A second scenario is, just you have mentioned, the patient might be having other diseases which mimicking COVID-19, just because they had a history of COVID-19, but the second time, after some time, they have got another disease, maybe adenovirus, or even flu. They believe because they have a very bad experience having COVID-19, so they might suspect they have disease again. And finally, we as medical staff, we are really concerned whether the patient is going to have the disease constantly, just like HIV or HBV or HCV. they have disease constantly. They can pass disease to others, even they do not have symptoms. That would be nightmare for all humankind, or for the mankind. It would be nightmare. But that's against the common sense. Just because for pulmonologists, you will see a patient have disease affecting the respiratory tract. It's virus, and it's always there. They can pass the disease all the time. It's just very hard to believe. So personally, I am quite optimistic that patient will have a certain period of time for immunity, which means they possibly or probably cannot have the disease again, at least for a short period of time. That's more in accordance with viral disease. But we need evidence, so we would like to wait for the further investigation and also public health surveillance for antibodies to come out to answer these questions.
Yeah, so as a pulmonary specialist, I think this disease is classified as a lower respiratory infection. And I'd like just to know a little bit more information about the relation between the lobes of the lungs and the RBCs in general. There are some relation between the RBCs and the other blood problems related or they come after this kind of contact between the lungs, the lobes of the lungs and the blood.
Well, that's a very interesting question. Well, I'll try to answer from my part, and my colleagues, Dr. Wu and Dr. Ting, will add their information if necessary. You have talked about the blood cell. We do CBC among every patient, and an interesting phenomenon we have observed is the lymphocytopenia. The patient all underwent lymphocytopenia, decrease of lymphocytes. And if the patient enter a stage of critically ill disease, the lymphocyte is usually lower than other moderate disease patients. And also among the survivors, we generally observe recovery of lymphocytes, which might imply the restore of their immune system. But among those non-survivors, the lymphocyte still always remain in a lower level. If they did not die of other secondary infections, the lymphocytopenia are always there. That's an interesting phenomenon we have observed. And for answer another part of your question, from perspective of pulmonologist, we believe the patient can be divided into three groups. The first group is mild to most of the moderate disease patients. They will have grounded glass opacity on their CT scan, but generally in this group of patients, the opacity will go away. They're going to dissipate, and the lung will recover. For this group of patients, we are quite optimistic their lung function will not be affected, at least not affected very much. And second group people is critically ill or at least severely ill. They're gonna lose some of their lung function. They're gonna leave some lesions in the lung. I believe the lung function test and also their working capacity will be jeopardized, at least for some time. And also the third group will be the critically ill. As we have mentioned previously, this group people mortality rate is very high. And I believe if they are fortunate enough to survive, the lung function will be impaired to a very large extent. So for this group of patients, close monitoring, very precise evaluation, and also rehabilitation will be very important for them.
Okay, thank you so much, Dr. Fan. Dr. Ding or Dr. Wu, do you have anything to add on that, or we can go to the next question? Okay.
No.
Okay, Dr. Karajah. So how about you? Let's try with you again to see if we have your audio back. So can you proceed with your question, please? Thank you. We can't hear you. can you talk a little bit more? Yes. No, can you try to ask that question so that we can see we can hear you? No, we can't hear you. I'm so sorry. So yeah, let's see what are the problems. So how about let's go to Dr. Amlach. So yeah, you can just proceed with more questions, please. Go ahead. Dr. Amlach, Dr. Isa Amlach, yes, please go ahead.
Yes, with you. Yes. What's the specific treatment used in the Wuhan hospital to treatment the patient with COVID-19 in ICU or in the medical ward? What the specific treatment or the specific medication?
I think this question best go to Dr. Ding Xu. Yeah.
Okay, just as Dr. Fan said that we don't have some very specific medication for these patients, especially in the patient in ICU, because we have to make sure that you are dealing with the symptoms caused by the virus. We will call that viremia, virus itself, or you are dealing with the complications caused by the virus. For example, in the ICU, maybe some symptoms of the respiratory symptoms, because such as dyspnea or hypoxemia, are caused by the virus, which will make the lung you can got not enough oxygen. But you are dealing with several problems, such as nutrition. Maybe have bacterial infection. Maybe you have acute kidney injury, or that we call that complications about the complication caused by virus. And actually, when the patient comes to the ICU, that is very at the late stage. Maybe the mean time from the symptoms onset to the patient admitted to ICU is about 1 month in our department. So at that time, most of the patients got negative nucleic acid swab. So at that time, we are dealing with the complications. So first, I have to emphasize that no approved medication was effective in that case. And most of the time, we are dealing with the complications caused by the virus. So just the supportive therapy, we just mentioned that mechanical support, kidney support, nutrition support, that will be very important at this time. And what can we do is prevent this patient from coming to ICU. And if the patient just have symptoms, you give them enough support. Maybe you have some oxygen therapy, you give them nutrition support, and you can stop them from getting worse. And they don't have to get in ICU. And if the patient was admitted to ICU, most of your energy, most of your work is on the ICU itself, but not the virus.
Okay, thank you so much, Dr. Ting. So how about we take a short break from our expert discussions, and then let's take a look at the big screen to see some of the comments and and questions from followers on various social platforms. And so now let's take a look at number 1. So it's for the doctors from China, I guess. So did you divide the hospital in red zone and no red zone? So is that the kind of practice that we have been carried out in Wuhan? So who can answer that?
I will take that.
Go to Dr. Fan, yeah.
Okay, thank you, Dr. Wu. Well, here, in our words, actually, it's called 三区两通道, 3 zones, 2 corridors, where we would divide the ward, standardized quarantine ward, into 3 zones. The first one is the polluted zone, which patients are hospitalized and taken care of. The second one is a buffer zone, which is the connection between the clean zone and the polluted zone. And the 2 corridor, which means the clean corridor, which if you will take off your PPE and N95 mask, you can walk out from the clean corridor. But if you have to, transfer patient or supplies, you will go to the polluted corridor. It's a module which are widely adopted in Wuhan and strictly adopted. We, generally very strictly obey this rule: 2 corridors and 3 zones.
So these are actually, so the 3 zones, 2 corridors is not only in the hospitals where you staying, it's actually more like a guideline for almost every hospital in Wuhan, where other cities treating patients with COVID-19. Can we understand that way?
It's a routine setting.
Yeah, universally applied.
Okay, great, thank you. And now let's go to the second question. So what is the nurse-patient ratio in designated ward? Maybe it differs from hospital to hospital, I guess, but what about in the hospital that you stayed in Wuhan? So how's the ratio like between nurse and patients?
So we have 32 beds in our ICU, and we have 130 nurses. So it's roughly about 1 patient with 4 nurses. That's our ratio.
Great. So, and the third one is, how often or in what cases did you perform team tests?
We don't universally do the team test. So, which means that we don't universally test every team members in our team. But after the first couple of weeks, we do offer the test for our team members, but it's voluntary, it's not required. As long as you have no symptoms and as long as we all follow the guidelines and the protocols and we are protected well, I don't think it's necessary to test the team members without any symptoms or other abnormal signs.
Yeah, agree.
Okay, gotcha.
Yes, I have to add that we never do team test during the work. When we are working in the
among doctors, medical workers, right? Doctors and nurses, which you don't do often.
Yes. We just we think the question is about medical workers, medical staffs, the nurses and the doctors. And when we are working in Wuhan, we never do team test, and we just think that we are protected very well with the PPE. And for our question, after we left Wuhan and we have to our quarantine here, we just follow the national standard that if you want to just if you just have 14 days and you want to go home, you will do a test. But we don't think that that's called a team test. But we all of our members get a test before we can go home.
Okay, so now I think we have time for the last rounds of questions. So for those, Dr. Saleh and Dr. Amlach. So do you have more questions?
Yeah, I think there's a good ratio between the nurses and the patients, 4:1, which is good. But doing the team test very often, maybe it goes upside down because all the help is needed. Because from what I see, the team, the medics or paramedics, they leave the front line after they are totally exhausted or finished. Not, but I wish all of the best for the medical teamwork because they are more than what they are supposed to do. God bless their hearts. I do have a question regarding the nutrition part in managing our treating patients. As you said, you treat the complications beside the nutrition part. Is there a specific food like herbs, leaves, liquids, something unique in China that it could be used as medicine in the future?
You mean the medicine in helping people improve their immune system, or it's nutrition that helps?
Well, yeah, nutrition definitely it helps the immunity, the immune system. What kind of is there a specific food served to the patients that could be of good intervention or good support for cure?
For curement. So.
And I heard that there are some kind of herbs, fluids in China, because I heard that it's not only medicine, but there is
I mean traditional Chinese herbs or traditional Chinese treatments.
This is yeah.
Okay, because
we like to know about it.
Okay, because the doctors we had are not traditional Chinese. They don't focus on traditional Chinese medicine. But let's see, because I think. But
I do have some comment, because in our ICU we also use some herbs. We use some traditional Chinese medicine. For example, some of our patients have illness. Their bowel movement just stopped. So we use some traditional Chinese medicine to treat that, as laxatives. And because that will enable us to proceed with to enteral nutrition. Otherwise, the patient, the bowel was dilated so badly, you can't actually feed them anymore. And but we don't know. We don't know if those herbs can just treat take care of those complications, or they can restore immunity. Because I think the Chinese traditional medicine, they have a totally different philosophy as compared with the Western medicine, because they are two different systems. So I have no pros or against Chinese traditional medicine. But if we still, I think that if we want to say which kind of a specific drug is effective, no matter Chinese medicine or Western medicine, we should do RCT to prove it.
Yeah.
Is there a protocol, implemented a protocol for those who are recovered to be followed later on? And is there a mandatory, or they expect to have a mandatory using masks at least for in the coming few months or in this time?
I think this question goes to Dr. Ding Xin. I will try to answer the Dr.
Raja maybe, or
question. Yeah, because he couldn't use the audio, so I will chat with him, give him some message.
Okay.
Yeah, go ahead.
Yeah. Okay, I just to ask a question. Actually, first, we don't have some standard protocol to boost the natural immunity. Just like Dr. Wu said, that we don't have some nutrition like food or herbs that can boost the natural immunity. But we do have standard protocol in quarantine, because if you are in a hospital, if you are in
we're losing his signal, right? Can you see or hear Dr. Ding?
Not really.
Okay. Yeah, I think his has like a weaker signals now. So Dr. Fan or Dr. Wu, can you answer that while Dr. Ding is trying to reconnect with us? Or we can just wait for him?
Yeah, sure. Dr. Fan, go ahead.
Was Dr. Salah asking about whether the patient have to wear a mask after recovery? Was he asking about this question?
Yes, this is one of the.
Yeah.
Is it a mandatory to wear masks in the time being?
Yeah. Well, we recommend, or we even require all the patients who has been diagnosed with COVID-19 wear a mask, just to to avoid their spreading the disease. For other people or for the general population, I believe right now here in China, in the public space, all people are encouraged to wear a surgical mask just to avoid droplet spreading. Although the occurrence of disease right now here in China is very low, but I believe that's the choice of most people. Among our medical team, we are quarantined for 2 weeks. But if we go out for a meeting or some work, under organization, we all wear a mask. And it's kind of a habit right now. Just a special measure for social distancing in a Chinese way. So the mask problem here is not that hard.
Right. So now it's great to have Dr. Ding back. So Dr. Ding, you can just continue with your answer from the last question. Just now, I think
heard the ending of the fan. Okay, I will
no, we still can't hear you. Can you keep talking so that we can see if we can hear you? It seems we have lots of technical issue today. Okay, still no. Okay,
can I ask
now.
a question?
Yes, please go ahead. Yes.
Yeah. What's the ratio between male and female infected people? Is it and why it is? Let's say if the infected males are more than the infected females.
Dr. Ding, can you hear us?
No, I think we lost him. He's trying to log in again. Sorry.
Okay. GP will take the question. Yeah.
We're trying to ask it. The sexual preference differs between different reports. We haven't obtained the final result among the 80,000 patients who have got COVID-19 here in China. Personally, or as a team, we did not observe sexual or sex preference of this disease among ICU patients. I believe the patients we have, been treating, the ratio between men and women are similar, and also it's supported by other reports. We used to suspect that there's male predominance, but actually it did not go that way. After we have all the statistics.
As a pulmonary specialist, do you think smoking factor has a risk factor for the
it's an interesting question. Well, I believe smoking can jeopardize the lung function. I would like to charge the smoking as underlying condition among these patients. If the patient is a current smoker, I believe he will be labeled as an underlying condition.
Regarding the immunity, or regarding the sort of infection, because the smokers they are currently using their mouth, face, different areas. So
I think it's
the
both.
chances for the infection are high.
In a behavioral way, and also the medical.
Okay, thank you. So how about Dr. Amlach? Do you have more questions?
Yes, I have a question. We see in the all worldwide, the mortality rate is high in the chronic patient that have hypertension, heart failure, diabetes mellitus. We see a lot of patients, COVID-19, child and children, but asymptomatic and resolved the COVID spontaneously and smoothly without complication. No, you have experience about why the children and the infant not effective with COVID-19, no mortality rate, no complication.
You're talking about cases with spontaneous recovery without any medication, hospitalization. Yes, we do have some patients here in China too. Because in the early stage, before all the 8 medical teams sent to Wuhan from all over this country, actually the medical system, the local medical system in Wuhan has already been overwhelmed. And you see that patients are very sick but couldn't be hospitalized. So we do have some patients that where usually they are young and healthy without any underlying complications. They just stay at home and treat themselves by fluid, those control the high temperature, the fever. So they just recover in 1 or 2 weeks. This is true for the young people, but it's not to say that you don't need to see the doctor. First of all, you need to see the doctor. But if the doctor say, well, the risk for you to progress to severe or even critical cases are very small, then I think it's relatively safe for this patient to stay at home.
Okay, so now I think before we wrap up, we have a new guest joining us is Dr. Tayyeh, who has been actually on the line with us through video, joining our conference. So, Doctor, I saw you have raised your hand, who want to pose want to raise a question. So yes, please go ahead, Dr. Tayyeh. You can ask your question now. Dr. Fakari, Tayyeh, can you hear me? If you can hear me, please go ahead with your question. Okay, it seems that we can't hear him through some audio difficulties. So, okay, so gentlemen, before we wrap up, do you have more questions for Dr. Fan, Dr. Wu, and Dr. Ding? Do you have more to add on that?
I have a comment to add, if you allow me, please. Actually, everyone is observing the unique development in China. The eyes of the whole world are open on China before, during, and after. When they were very successful, some people were jealous. And when you had coronavirus, all of those jealous people were quiet. They stopped doing anything. After you recovered from this problem, they just opened their eyes. So what I say as a Palestinian, I like to see my neighbors successful, healthy, not starving, dress well, eat well. So I'm proud of the Chinese development and their human rights concern regarding in China or in any other country in the whole world. So God bless your heart and keep your eyes open, and hoping that this crisis will be removed. And now fighting, I hope people will be well behaved after this crisis is over.
Thank you very much.
Thank you very much.
Thank you for your support. We also sincerely hope that your patients will recover soon and where people will get back to their normal life. Thank you once again.
I hope so. Thank you.
Okay, thank you. So if there's no more questions or comments from doctors from China and also from Jordan or Palestine, so we're just going to wrap up today's discussion, which in our dialogue, the doctors from China and also their international counterparts has addressed some of the most pressing issues that they have faced concerning COVID-19, such as the specific medication for treatments, as well as how to deal with asymptomatic patients and also more. So I think hopefully the experience and also the thoughts, the scientific information shared from Chinese doctors as well as their international counterparts can help them to better fight this pandemic and also jointly safeguard global health security. So thank you so much everyone for your time and also your contribution, and a big thank you to our followers for your attention, and more live streaming in the upcoming days. So thank you and bye.
Bye-bye.
Bye-bye.
Good day.
Bye. Thank you everyone. Bye.
Good luck.
Have a good one. Take care.
Good luck.
Thank you.
Thank you for being open to us and listen, which is good. Thank you. God bless your heart.
Thank you, sir. Thank you.
Thank you, sir.
Good luck.